total hip replacement is an operation we have to treat hip arthritis. So hip arthritis is as everybody knows, a very common condition in the community, and it causes a lot of pain and stiffness in the hip. A limp can cause a leg length discrepancy as well. And hip arthritis, the most common cause is called impingement, and that is where the shape of the ball is such that in certain positions it bangs against the edge of the cup, the acetabulum, and that leads to cartilage damage, which then can lead to widespread arthritis. Other causes of hip arthritis can be trauma, so fractures, inflammatory arthritis, where somebody's got rheumatoid arthritis, some other sort of inflammatory condition, and another condition called avascular necrosis, and that's often associated with heavy alcohol intake, where the blood supply to the ball is lost and that collapses and leads to arthritis. Irrespective of the cause, the treatment for hip arthritis from a surgical point of view is a total hip replacement. And it's a very, very successful operation. It's probably the most successful operation in the history of surgery in terms of relieving pain and providing good outcomes for patients. So hip replacement is where we take the ball away and we replace it with a stem in the femur and a cup. It's called the acetabulum cup. And that ball articulates on the bearing surface. And that bearing surface can vary from ceramic to plastic, but that allows you to move and relieves pain. So with total hip replacement, the goals of a total hip replacement are primary wound healing, bony alignment, and soft tissue balance. So combining those three, we can provide a good outcome for a patient. And getting that most accurately corrected is the key to good outcomes and low complication rates. So what I use is navigation in theatre, and navigation is where we put some sensors on the femur and the pelvis. That gets picked up by a camera, which is connected to a computer, and that gives us real-time feedback in terms of component alignment and soft tissue balancing. The things that we're trying to reproduce are the leg lengths, and we're trying to reproduce the offset. The offset is this distance here, and that affects the muscle tension and how well the hip functions. If we reproduce the patient's anatomy, then we've got the best chance of a stable hip that provides good long-term results. So that's a three-phase process. Pre-operatively, it's a clinical examination, and we do a CT scan. The CT scan gets analysed and allows us to work out potential component size, what the optimum positioning of the components are, and what the pre-operative offset and leg length is. And that gives us goals that we want to achieve in theatre. The navigation in theatre helps us reproduce those goals and gives us accurate feedback. And then post-operatively, we do x-rays and we can analyse those as well, and to ensure that we reproduce those goals. So how do we do a hip replacement? There's two different approaches to the hip. You can approach the hip from the posterior, or you can approach it from the front, and there's advantages and disadvantages. My preferred approach is the posterior approach, but a very common approach also is the anterior approach. The advantage of the anterior approach is that it does go between muscles, and there potentially is less soft tissue disturbance. The acetabular preparation is easier, but the femoral preparation is much more difficult with an anterior approach. With the posterior approach, it's the opposite. The acetabular preparation is a little bit more difficult, but the femoral preparation is easier. Either way, at the end of the day, at about 6 weeks, whatever approach you use, if you get the three goals that I talked about correct, then the patient does very, very well. With hip replacement, like any surgery, there are the potential for complications, and they can be related to the anaesthetic, But specifically with the operation, there is a risk of infection. The risk of infection in hip replacement actually is very low, fortunately. It is a very serious complication if it does occur. The main thing we worry about are nerves and blood vessels. So the main nerve at risk is the nerve coming around here called the sciatic nerve. With an anterior approach, it's the femoral nerve at the front, as well as a nerve that comes across that supplies feeling on the outside part of the thigh, called the lateral femoral cutaneous nerve. So we're very, very careful with surgery to prevent any problems with nerves. The blood vessels are at risk of the femoral artery at the front here, and obviously if that's injured, that's a serious problem, but fortunately that's extremely rare. The other problem can be leg lengths. So it's very easy to lengthen somebody's leg putting in a hip replacement. And if you start getting a discrepancy up around a centimetre, people can become aware of that. It can cause long-term problems. So the navigation increases our accuracy and reduces the risk of a leg length problem. The other problem that can occur is dislocation, where the hip can pop out. So that's where component orientation and soft tissue balancing reduces the risk of dislocation. The other thing that can occur is a fracture or a crack in the bone with putting a hip replacement in. Often that's just an undisplaced crack like on a hard-boiled egg, and we can put a wire around there to prevent that from getting worse. Sometimes it's more complicated than that. Despite these problems, hip replacement is an extremely successful operation. It relieves pain, it restores function, improves the quality of people's lives. And that's why so many are done, because it's a common problem in the community. With careful preoperative assessment, intraoperative navigation, then that maximises our chance of providing a good outcome for the patient.